Welcome everyone, good afternoon. Thank you for joining us today on this chilly Tuesday. I hope you're all keeping warm. It's so exciting to see the level of interest in this fellowship. I can't believe so many people have joined this webinar, so thank you so much. My name is Fiona McIntyre, and I'm the Fellowship Admin Manager at this Institute. And I'm here today with my Institute colleague Tara Lamont, who is the Senior Advisor to the Fellowship Programme. And we are delighted to be joined by our guest speaker, Rohini Mathur, Professor and Chair of Health Data Science from Queen Mary University of London. The purpose of the webinar is to allow us the opportunity to explain why we need new research in this area of equality, diversity and inclusion in healthcare, the details of this fellowship call, what we're looking for in a good application and what the fellowship programme can offer. We are assisted today by Sushma Sanyam and Olivia Waghorn from our Communications and Engagement team. So before we kick off, bit of housekeeping. This first section of the webinar is presentations and it will be recorded. It will be made available for viewing in the next couple of days, as well as a Q&A transcript. We anticipate the duration of the presentations to be around 45 minutes. And after which the recording will be stopped and we'll open up the session for questions. If you have any questions that pop into your mind as we go along, please feel free to put them in the chat. Or if you cannot stay for the Q&A session, please put your question in the chat and we'll answer them offline. As there's so many people on this call, to help us manage the Q&A session, what we've suggested is if once we get to that section, if you pop your name into the chat, and we'll come to you in order that the name was added, and we'll ask you to unmute and ask us your question. We've allowed 30 minutes for the questions, but if it looks like we're beginning to run out of time, you will have opportunity to pop your question in the chat, and again, we'll answer them offline. We do ask, don't use the Q&A session for scoping out your individual projects. This session is about asking general questions about eligibility, the fellowship offer, the application process, that sort of thing. You are welcome to submit a brief summary of your proposed research to the fellowship team at the email address you see on the screen, and we'll have it reviewed and reply to you. In addition to that, next week, we're offering an opportunity to discuss your proposed project with Tara. Appointments are limited and they're on a first come, first served basis. If you'd be interested in scheduling an appointment, again, please email the fellowship team at the address on the screen. So let's get going. So for anyone who's unfamiliar with this institute, I'll just take you through a little bit of background. The institute was set up in 2017 and is led by Professor Mary Dixon-Woods with the aim of achieving the goal that you can see on the screen. Sorry, bear with me, my notes have just juggled to another screen. Our work is underpinned by the principle that efforts to improve care should always be based on the highest quality evidence. So we're boosting research activity by providing more clarity on what works, what doesn't, and why. The Institute hosts around 60 members of staff made up of research teams, communication and engagement experts, study support teams, operational staff, and the discovery team, who manage an online platform which makes it possible for people to be involved in research and consultation projects. As well as our own research, we developed our flagship fellowship programme, which is to address one of our strategic aims of growing capacity and capability in improvement studies and to advance the field by investing in talented researchers. Around a third of our overall funding has been committed to the fellowship programme. The programme commenced in 2018 and offered a range of fellowships at doctoral, postdoctoral and senior level. In 2020, we added a theme scheme, which allowed calls to be themed around a specific research topic. And this is open to researchers of all sort of backgrounds and disciplines and range of a stage of career. The first 3 rounds of funding in this scheme focused on topics related to emerging issues of the pandemic. We've since grown this scheme to fund fellowships in the areas of green and sustainable healthcare and perioperative care for older people. This strengthening equality, diversity and inclusion fellowship sits within this scheme theme. themed scheme. Sorry, that's quite difficult to say. This, we're very proud. We've made 54 awards to 24 universities across the UK, and you can see the spread on the slide on the screen. So our wonderful fellows are reimagining what improvement research looks like and strengthening its scientific foundations, as well as extending reach, impact and influence. And Tara will be giving some examples of individual fellows and the projects a bit later in the session. But right now, what I'd like to do is pass over to our speaker, Rohini, who will explain why equality, diversity and inclusion is important for healthcare improvement. So over to you, Rohini. Thank you.
Thank you so much. And thank you for having me at this webinar today. It's wonderful to meet you all. So my name is Rohini Mathur, and I'm based at Queen Mary University. I'm an epidemiologist with experience working largely around ethnic inequalities in health using UK-based electronic health records. And I'm sure this is familiar to most of you, but I'll just have a quick overview of what is ethnicity and why it's so important to examine this in relation to healthcare outcomes. So in the UK, and indeed in many other settings, ethnicity is considered to reflect an individual's own self-identification. And this encompasses a broad range of socially constructed characteristics, as well as some biological and genetic variation. So this can include aspects such as people's beliefs and behaviors, their culture and language, and also their experiences of racism and discrimination. And the fact that these factors are distributed unequally in different population groups can be conceptualized as ethnic differences. And so ethnicity as a concept can be thought of as a basket, which allows us to explore and unpick all of these different drivers of health inequalities. And we know that the relationship between ethnicity and health is complex. It doesn't always go in a single direction, and it is very specific to the context of geography, politics, and time period. And indeed, the way we think about ethnicity in the UK is different to the way we think about it in different countries and in different settings. And it's really important when conceptualizing inequalities in relation to ethnicity that we're talking about the fact that health outcomes are determined by factors associated with ethnicity rather than anything innate about an individual itself. It is a social concept and is fluid in that respect. So it's really important to capture ethnicity data, mainly to uncover potential patterns of disadvantage and racism, which would otherwise remain hidden. We need to describe and make these differences apparent before we can address them. Oops, I was not controlling that. Great. And as I mentioned before, ethnicity is a useful lens through which to describe disparities. It isn't the only one. And of course, ethnicity intersects with a range of other really important indicators. But it is something that we have routinely captured in UK settings, thanks to the fact that it is the law to capture ethnicity data in all government and healthcare settings. And this is somewhat unique in Europe. The UK is the only European country which requires this. And in many other European countries, the capture of ethnicity data is in fact illegal. Thinking about the social context in which we capture ethnicity, ethnicity really shows how people have been racialized, which is shaped by historical and political forces. And so this helps us think about structural and infrastructural impacts on inequalities, which we can address through interventions. And I'd like to just talk briefly through an example from our East London context from a few years ago. Oops, I've got one more slide about biases of ethnicity data, which is just thinking about when we capture ethnicity data in UK settings, we want to think carefully about who has their ethnicity data recorded and who doesn't. People who have their data recorded, maybe people who are healthier, who have good access to healthcare. People who don't have their ethnicity recorded, maybe less able to access healthcare, maybe more mobile, or maybe less likely to be asked about their ethnicity. So we need to think about data quality and methodology very carefully when conducting this kind of research. So the example I would like to talk about is an intervention that we had in East London to improve the uptake of MMR immunization across Tower Hamlets, which is a very ethnically diverse and highly deprived borough of East London. And in the study period between about 2006 to 2008, Tower Hamlets had the highest rate of confirmed measles in the country, with about 24.6 cases per 100,000 people, compared to a national figure of 2 per 100,000 people. And before the intervention, we conducted some focus group work across Tower Hamlets, which indicated concerns in the Somali community about the MMR vaccine, particularly around fears of autism. And thanks to the high quality ethnicity data we had available in our electronic health records, we were able to separate out people of Somali ethnicity to investigate their healthcare usage and needs more further. We found that compared to South Asian children who had the highest rates of MMR vaccination, MMR uptake was 45% lower in white children and 76% lower in Black African children. And however, when we brought out the Somali community separately, we found that MMR uptake was 92% lower in this group. So this allowed us to develop some targeted interventions in Tower Hamlets, and we were able to implement a call and recall program to improve MMR uptake. And we can see that after the intervention, the uptake of immunization was fastest in Tower Hamlets and exceeded the national average. And so this work really just demonstrated the value of having ethnicity data to uncover inequalities, to design interventions, and to achieve healthcare quality improvement, which benefited both the local community, but also on a national level as well. So thank you so much.
I think I've got control now. Thank you, Rohini. I think you've shown us with that example why what good research looks like in this area, and why we want to fund more and different kinds of fellowship projects. Just to start a bit with the background. Sorry, it's still not moving. There we go. So starting with some of the differences that we know about, many of them avoidable in sort of health and outcomes depending on who we are and where we live. So looking at these kinds of figures, a lot of these have roots in wider social factors outside the scope of health. But healthcare itself may contribute to some of the important differences in access to healthcare and in outcomes. So there are different chances of getting to certain services and different experiences of care once there. And so against that background, the healthcare, this institute, as Fiona has said, with its important mission of improving quality and safety of healthcare, we want two things really. We want to bring some of that improvement expertise, to bring projects and people who know a bit about improvement science to bear on the equity challenges in healthcare. But we also want to bring scholars in the field of equity and diversity into healthcare improvement. So recognising that there are important areas of academic and service knowledge which we perhaps don't have in healthcare improvement at the minute. So in terms of putting this call together, we focus particularly on 4 areas. So the call itself is quite broad, but we want to attract projects, first of all, around sort of improvement itself with attention to equity, diversity and inclusion. Secondly, to look at access to healthcare services and how that can be improved. Looking at diversity and equity in the NHS workforce And then lastly, and really building on Rahini's examples of areas around data measurement and methodology to strengthen equity improvement research. So in this first area, which is perhaps the broadest of the four areas, I think the backdrop to this is that in improvement efforts generally, we're looking at variations in quality of healthcare and what can be done to address this. But some sort of well-meaning improvement efforts may ignore or overlook or kind of smooth out some important systemic differences in the experience and outcomes of healthcare. In improvement terms, what that might mean is that we might actually reward high-performing organisations in affluent areas, reinforcing perhaps what we already know about inverse care laws, that is, that the areas of greatest need might get the poorest levels of healthcare services. So, for instance, affluent areas often being over-doctored. But in improvement science terms, what it might mean is that quality incentive schemes, such as QOF schemes in general practices, might actually reinforce existing patterns of inequality and advantage. So we want to look at improvement efforts with that lens of equity, to look at how schemes might reduce or perhaps exacerbate inequalities. We also want to look at population and groups which we know have levels of disadvantage. For instance, people with learning disabilities or severe mental illness with shorter life expectancies and poor access to health services. And under this umbrella of improving improvement, we also want to look, as in this illustration here, around what bias there may be in existing tools used in healthcare treatments and services, such as pulse oximeters, which work less well in people with darker skins and may fail to pick up worryingly low blood oxygen levels. It was a real issue during the pandemic. So we want research that can address these and other important areas of equity to do with healthcare improvement itself. The second area around access, and as I've said, we know that patterns of use of services are not related to need, and that there are different kinds of patterns. So, for instance, disadvantaged groups may make less use of planned preventative services. In that earlier background data, we saw higher rates of emergency hospital admissions for people living in the poorest areas. We know that people in more affluent areas might get higher levels of specialist services and some treatments. For instance, those in more advantaged areas are 3 times as likely to get hip and knee replacements. We know also that, for instance, people in minority ethnic groups are less likely to refer themselves or to be referred by GPs to CBT and other talking therapies. And one of the explanations for this is a theoretical framework called candidacy for access, which describes the ways in which whether people seek or get treatment may depend on both structural and cultural factors in the organisation themselves, and in people seeking help, which might affect expectations and behaviours, both in accessing services and in the gatekeepers, if you like, for those services, around ideas of deservingness of care. And in this area of the call, we're interested in initiatives which can really help with understanding efforts in the service to improve access and to make access more equitable or targeted at certain populations, and whether such efforts, taking into account some of these complex contextual and cultural issues, can be successful in driving more equitable access. We have an important focus on the workforce. We know that the NHS workforce is very diverse. More than 22% of NHS staff belonging to minority ethnic groups. And since 2015, NHS organisations have been required to report activity against key standards on race and disability. And we've seen some progress in that time, for instance, in appointing very senior managers from Black and minority ethnic groups. But there's still, in this annual reporting, we still see sustained continuing levels of staff bullying and harassment, which is higher for minority ethnic groups. We see, for instance, that disabled staff are twice as likely to be referred for formal performance reviews. So we really want to invest in more research to find out what can be done to counter some of these high levels of discrimination, microaggressions and so on in organisations, from staff and from patients. And what can NHS organisations learn from each other about those that are doing well in terms of progressing equality standards? We want to draw on a rich seam of health services research to understand better around questions of organisational culture and leadership. And we want to know what would kind of structurally competent organisations look like, i.e. not just focusing on staff training, individual awareness on race, but what would systemic and structural interventions look like in this space. So there's a lot of interest around improving equity in NHS workforce across the piece. And our last area is around data and picking up on some of the themes that Rohini mentioned. So we know from work of the NHS Health and Race Observatory, thinking about work with the Nuffield Trust and others, there are problems in the kind of quality and completeness of data in areas like ethnicity and disability. So for instance, only 60% of community data sets have complete data on ethnicity, with much higher levels in hospitals. We know that there are patches, there are gaps in terms of occupation and employment data, which might be really important for targeting work directed at economic and other disadvantage. We also need work in this area to do better analysis linking different data sets. And I should say that the scope of our call, we talked a lot perhaps around ethnicity, but the scope of our call is for all aspects of equality. So looking at all protected characteristics and looking at areas like socioeconomic disadvantage and the interplay between these dimensions and any sort of intersectional effects. So thinking about data in that, how we can better measure, understand and evaluate sort of interventions to improve services in these areas is a really important area for new kind of methodological and underpinning work. So in terms of what we're looking to fund, as Fiona said, I mean, this is a targeted fellowship. It's open at all levels postdoctoral. So we're looking from early career researchers through to senior investigators. And really the hallmark of our fellowship projects to date, as Fiona said, they're an amazing pool of more than 50 very, very different kinds of projects and people. I guess what they have in common, many of them are kind of hybrid. They've worked across different disciplines, across different fields, and they're interested in tackling real world problems. So I just thought, I guess too, in terms of not just the kind of paper qualifications, but in terms of temperament, I feel that a lot of our fellows, who are a pleasure to work with, are very curious and open, and looking for opportunities to work with each other and across some of the various research activities of this institute. If I can just give you a flavour of some of our current fellows, I could have chosen really any 3 or 4. They're all fascinating. But on the left here, see Debbie Clark, who's a critical care nurse with an interest herself in kind of simulation and training. But her particular project is focused on safety standards. So in patient safety terms, standardization is seen as a really important way to address avoidable harms. But in practice, many staff, for good reasons, might work around some of the existing safety standards. And Debbie's project is using really ethnographic methods to understand, in critical care and in other settings, why might be the reasons why teams and individuals may work around existing safety standards, and then working collaboratively in a kind of co-design way, picking up some of the learning from this observational work. She's planning to identify with staff some of the conditions for safe workarounds for wider learning. So I think it's a really nice example of a sort of practical project, if you like, arising from her own experience, but using kind of theoretical framing and some rigorous research to really shed new light on this. The second example on the right, Anup Shah, he's an acute physician with an interest in clinical informatics and AI. So he's using what's called natural language processing, where he's mining the free text of GP records. He was originally focused on heart failure, but his project started just as pandemic kicked, and he switched to looking at the emerging problem of long COVID. So mining GP records to get a better handle on some of the kind of diagnostic terms that could be helpful, and using big data analytics and AI to help to improve the kind of diagnostic grouping of some of these emerging symptoms. If I just carry on with a couple of other illustrations. And on the left here, Karan Barki, one of our newer fellows, is one of the themed fellows Fiona mentioned. So we put out a priority call around sustainable healthcare, greening the NHS. And Karan was one of the small cohort of fellows we funded. He's got an engineering background, more recently has worked in healthcare with some understanding of social sciences, and bringing these really rich different skills. He's looking at waste management in the NHS and looking at how during the pandemic, the greater use of single-use devices and materials, and how it raised the thresholds for what was deemed clinical waste, and how new sustainable clinical waste policies could now be introduced. And he's doing that using sort of participatory methods, but also using kind of quite interesting, new to the Institute approaches, like doing bin audits at 2 trusts in the Northwest to really get some practical improvement change and evaluate the impacts of that into hospitals. On the right is an example of one of our senior investigators, Graham Pullin, who's just finished a really interesting project. He's a professor of design at Dundee University, and his work is on the interface between design and disability. So he's looking at how people choose prostheses. And as part of his project, he held an open exhibition at the V&A Centre in Dundee to ask members of the public to design their own prosthesis and to think about what they would consider in terms of function, aesthetics, identity, what was important to them. And his project, and you can access some of his outputs on our website, and I would invite you to browse through the fellowship part of our website to get a sense of some of these other projects and the outputs of some of the completed works like Graham's. Graham's work includes 4 films featuring conversations between different scholars and experts by experience. So he's in conversation with, for instance, disability scholars and activists, rehabilitation scientists, OTs, artists. It's a really fascinating interdisciplinary project with some practical outputs and use. So I think in terms of what we're looking for, we obviously want your project to be driven by the importance of the topic in terms of the potential to improve quality and safety of healthcare. But we're not prescriptive about the study design. As you can see from those examples of fellowship projects, they used a range of different methods. But we do ask that you think carefully about the appropriate methods for what you plan to achieve, and that it can be delivered within the 2 years of the project or longer part-time, that it's feasible and can be delivered. You will essentially be the principal and lone investigator of the project, so it needs to be delivered as a personal award within that scope. We're interested in funding the project and the person, and we want to see a track record of relevant, but I think I've indicated that our definition of relevant includes a range of disciplines, including work outside healthcare, but we would like to see examples of the work that you've done, not just in terms of academic scholarship, but also perhaps engaging with NHS or other partner bodies, and perhaps reaching wider audiences than just academic papers. We want to see an awareness of healthcare improvement, but also relevant theory and practice in terms of equity and inequalities, and drawing on, where appropriate, those kind of fields of scholarship. And we want to see careful and embedded engagement, whether it's with patients, with staff group, with community groups, with advocacy groups. We want to see that built into the project and costed in appropriately. We we welcome applications from any part of the UK, and your fieldwork can be based in any part of the UK. We ask that your project attends to one of the 4 areas I've outlined, but which are quite broad in scope. But we're looking for innovative projects, including within those broad categories, things that we might not have specified by name in the call. We're looking for projects based in any healthcare setting, and we're aware that often projects can be acute focus, so we're interested in all projects across community mental health and indeed across field work that spans a number of settings and looks at integrated care services and systems. While recognising the limitations of what you can achieve in a two-year project of this type, we recognise that it could very well be to develop and test and evaluate complex interventions in 1 or 2 NHS settings. But we do want you to think about what the wider generalisability might be. So thinking about the characteristics of those localities and the populations they serve, and what could be done to generate more transferable findings. So I think based on our experience, as Fiona says, we've probably sifted through hundreds of applications for previous calls. I think you know, some of the pointers that I'd say is really think about telling the story of the problem that you're trying to address and why it matters. Do spend time on the short plain language summary. It's the first thing that the panel and the external reviewers will read. And it will really, it's quite telling in a way where people can or can't say clearly what the research they plan to do, why it matters, and how they plan to do it. So spend time on that. I always say simple is not easy. But also not just about your project, but we really want to know, in the space in the form, to say a little bit about you and your trajectory. How did you come to be interested in this? How do perhaps the different parts of your career feed into this project and this fellowship application? And why you'd be a future leader in this space. Our aim overall is to invest in a small cohort of thought leaders who will really shape thinking and practice in equity and improvement research in years to come. So tell us why you are that person. We always say, you know, we don't fund service quality improvement projects, we fund improvement research projects. So I think probably the most common reason for screening out applications is that they are service improvement projects without that research focus. So we are a research institute, so we're looking at you know, academic projects, but focused on improvement and real world service problems. And then lastly, and Fiona's just going to talk us through briefly our leadership support program, but it is a fantastic personalized program of coaching, peer learning, and opportunities to join together with this community of improvement fellows. So we really want to know that you are open to developing skills and developing community in that way. So I'll just hand over to Fiona now to follow up on the fellowship offer.
Thanks, Tara. Right, so the fellowship that is on offer, as we've said, it comes under the themed category. The funding is available up to 220,000. This is the maximum sum, regardless of the length of project or whether it's a clinical, non-clinical fellow. Fellowships can be held full-time for up to 2 years or part-time up to 36 months. To fully engage with the programme, we recommend a minimum FTE of about 0.6 if you're planning to do it part-time. It is worth bearing in mind that we are expecting this fellowship to begin around September, between sort of July and September. And we do, because of our funding, we do have a hard end date for fellowship activity. It all has to be finished by 31st of December 2026. So if you are planning your timeline and are planning to do it part-time, please bear that in mind, that you're not finishing right up to the wire. Give yourself some extra time. Your fellows remain employed in their own university or organisation. You're not hosted at this institute or the University of Cambridge. And as part of the package, you'll be offered the leadership development programme, as Tara mentioned. It will be discussed on award, and it's customised to the specifics of the fellows' needs and your commitments, and the fellowship duration, that sort of thing. The programme may include, just for example, membership of a learning set where you join a cohort of other fellows. It can be coaching and or a mentoring scheme as well. And there's also opportunity to participate in this space, which is our annual conference, usually held in November. You'll join a growing network of improvement researchers, and we also hold a fellows only event annually, which allows fellows across all cohorts to connect and network with each other. And obviously now, as we're moving through fellowship projects, alumni fellows will come back as well. Applications must be submitted through our grant tracker platform. Closing is midday on Wednesday the 8th of March. If you can't use Grant Tracker for any reason, do get in contact with the fellowship team and we'll come up with a solution to get it into the system. Please bear in mind with your application that after the main applicant has completed the sections of the application, the head of department has to complete section 6, which provides their statement of support for the application. Once all sections of the application have been completed by all parties, it then needs to go to your designated budgetary authority. So this all has to be done before the submission. So please, just if I can say anything, give yourself plenty of time to make sure you can get it to your finance person and they have time to check it, review all your budget and approve your application, so it's in plenty of time. If at any point there's an issue with your application, if it gets stuck in the system or one of your nominated people can't access it for any reason, please do get in contact with the fellowship team and we can look into it further. We have some access rights where we have the ability to push things through if it goes wrong, but we do have system support as well that we can escalate to if there is a major problem. It doesn't happen very often, but it's technology, there's always room for glitches. Once the applications are submitted, it will go through a robust review process. There's a review panel, which is made up of this institute's senior research staff plus external experts. In the first meeting, the applications will be assessed and shortlisted for progression through to a peer review. The assessment will look at the host department's research and other activities, the candidate's track record in research, their experience and skills, the proposed project, and if the budget appears appropriate for the delivery of the research that's planned. We would expect to notify all applicants of the outcomes of this first round of shortlisting by sort of third week of March. After that stage, shortlisted applications will be sent for peer review, and applicants will also be invited to interview. The interviews will be held on the 25th of May and will take place over Zoom. The successful applicants will be notified early June if you've been successful in being awarded. All applicants will receive their outcomes and will receive feedback as well. And as I said, we hope that ideally you'll commence the fellowship sort of in the summer term and around September, but I say don't let that put you off. Contact us and let us know if you have to move, if you've got any trouble with the dates, and we'll see what we can work out. Right, and on that note, I should now end the recording, please, and we'll stop screen sharing and we'll open up to some questions. I think we've already got some in the chat.